these nuclei, and so that's why you see all these very strange presentations. And we'll look at some videos of the various lesions and the type of movement disorders that they lead to. But I should be able to tell you at this point whether your patient has involuntary movement or not is going to determine whether you have an extrapyramidal lesion or not. If you have an upper motor neuron lesion, you have a precentral gyrus, do they have flailing or tremors? Any of that stuff? No. They have spasticity, hyperreflex, blah, blah, blah. That you guys can say very quickly, I hope. Okay, so again, that involuntary movement, that lack of coordination, all those other signs are outside. So here we're looking at, again, the relationship of the basal ganglia. So this is my subthalamic nucleus, my substantia nigra, my globus pallidus, my putamen, okay, with all of the cortical regions. So we'll look at basal ganglia lesions in a moment. But again, what we're seeing is motor planning, being able to regulate start and stop movement, and being able to control movement. So you don't have that involuntary movement. They are not paralyzed. They cannot, it's not like a pyramidal lesion where they just voluntarily cannot contract that muscle. Then we've got our cerebellum. So our cerebellum, just remember, has two hemispheres. In the middle of the two hemispheres is our vermis. And what you're going to look, and on the bottom we have our tonsils. But when we look at the cerebellum, we're going to actually open it up in a moment. So here we've kind of opened it up. I'm not going to ask you to remember the somatotopy of the cerebellum, except to know that there is somatotopy. So you can have, there is a foot region, a trunk region, a hand region, an eye region, so that you can have a cerebellar lesion that affects one part of the body more than another. So there is somatotopic organization within the cerebellum. The other big thing that we'll look at is the different regions of the cerebellum. So we've got a spinocerebellum that we'll look at, a cerebrocerebellum, and a vestibulocerebellum. And they're going to have really three different roles in motor control. So the flocculonodular lobe is basically made up of the flocculus and the nodulus, which is basically outside of the hemispheres. We've got our vermis, and then we've got this structure on the bottom. So if you actually opened up the cerebellum, they call it another lobe, the flocculonodular lobe, which we'll look at that in a moment. And again, we've got our output and input to the cerebellum through the three cerebellar peduncles, the superior, middle, and inferior cerebellar peduncles. I like this picture. We'll go through it again when we look at this part. But if you look, the cerebrocerebellum, which is on the lateral parts, that's going to be going out to essentially the cortex. So the cerebrocerebellum is going to send information up to the cerebrum to motor plan so that I can have coordinated movement. So it's going to adjust those motor plans. Then we've got our spinocerebellum, which is going to go straight to the spinal cord to adjust the movement. So this is motor execution. And it's going to lateral descending system, which is going to be where? What muscles? What regions? The limbs. And the medial, which are the trunk. So the spinocerebellum is going to go basically to both the ventromedial and the dorsolateral pathways to control that movement. The cerebrocerebellum is going to go back up to the cortex to change the motor plan. And then our last is our vestibulocerebellum, okay, which is basically made up of that flocculonodular lobe, this extra piece here. And that's going to go to the vestibular nuclei. And that's going to do a lot of things. It's going to certainly help with our balance reactions. What is the other big thing that the vestibular system has to do?
VOR.
The VOR. It's basically, the cerebellum regulates the gain of the VOR. So it regulates how those vestibular nuclei are working. So if you have a cerebellar issue, you got a VOR issue. And then again, we've got our 3 cerebellar peduncles. We have our superior cerebellar peduncles. This is a cross section where we've cut the cerebellum off of the brainstem. So here's our superior cerebellar peduncles. Here's our middle cerebellar peduncles. They're huge, 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 huge. And then our inferior cerebellar peduncles. The superior are going to obviously be connected with the cerebrum. So we're going to connect the thalamus and cortex with the cerebellum to the superior. Then the middle is going to be that huge connection between the pons and the cerebellum. So this is a lot where our vestibular information is going to go through the middle cerebellar peduncle. And then the inferior is going to be connecting with the inferior olive and the spinal cord. So this is just looking at it from a more cellular basis. Bottom line is we do have a lot of, I'm not gonna ask you to recognize even the name, the vestigial nucleus, but there are a lot of nuclei in the cerebellum that we're not talking about. But if you can realize that there's 3 different regions: cerebrocerebellum for motor planning, spinocerebellum for motor execution, and then vestibulocerebellum for balance and eye movement, or VOR. So if you look at comparing, again, this is all extrapyramidal motor influence. We've got our basal ganglia, which is going to affect really across the cortex. So actually what we see with some of the basal ganglia lesions, or with a lot of them, we end up seeing a lot more cognitive involvement than we do with any other motor region. So basal, people with Huntington's chorea, for example, tend to have cognitive limitations. The cerebellum is very narrow cortical area. We're really talking about the premotor and the primary motor areas only. The basal ganglia will be to that supplementary. Remember, the supplementary is the area that's actually just the goal-oriented, not even the strategy, just the goal. So that's why we have a much more wide cortical. As far as the input from the spinal cord, basal ganglia is not this comparator. It doesn't have input from the spinal cord. It's not seeing what's happening and adjusting it. It's deciding to start the movement. It's deciding to stop the movement. It's regulating the movement. The cerebellum is very dependent on those spinocerebellar tracts for that subconscious proprioceptive information. Basal ganglia is not going to have direct spinal cord influence. It's going to do that through the cortex and through the brainstem. And then the cerebellum is going to do it through the vestibular nuclei, through the reticular nuclei, and through the red nucleus. So it's going to have more access to the spinal cord. So there's a lot more feedback loops with the cerebellum. So what we see as far as motor control, and I didn't say about this one, is one thing that you definitely see with basal ganglia lesions, it's the emotional qualities of movement. So what we see is as the emotional state of the individual changes, we see more or less involuntary movement, and we see them be able to have control of the movement better and worse, depending on their emotional state. Motor learning is thought to take place a lot in the basal ganglia, so it's that cognitive piece again with the basal ganglia. And while the cerebellum is much more the error detector, regulating, coordinating that movement, regulating how hard we hit, how far we reach, all of that is from the cerebellum. So this is looking at our pyramidal system and then our extrapyramidal. Again, it's all going to work together. We're going to have the basal ganglia and the cerebellum both having influence over that pyramidal system. So they're both going to influence the cortex to regulate how well. And there it is again. So motor's pretty complicated. We've got the ventromedial and the dorsolateral systems working together for postural control and limb manipulation. And then we've got a pyramidal system, the corticospinal, rubrospinal, and then the extrapyramidal, which is going to be our cerebellum and basal ganglia, how they influence motor. So add a few more fibers. All right. So again, we've got our two classes. So paresis and spasticity is really going to be our pyramidal system versus extrapyramidal being outside. And we'll look at some different ones. But basically with our pyramidal lesions, our weakness and our spasticity, we see this a lot with stroke. Typically our patients who are hemiplegic have a pyramidal lesion. With this, we also are going to frequently, just because of blood supply, have sensory loss, have visual loss, have language loss, and then certainly functional deficits. So let's look at some videos of different lesions. Are you going to fall asleep? You're going to be okay. We'll make them a little dark, but not too dark. So this is your classic pyramidal lesion. This is a stroke. So you see hemiplegia, you see lack of voluntary movement. You don't see any involuntary movement. And now here we have a patient with syringomyelia. What's syringomyelia? CSF. Myelia. Myo means spinal cord, like myelogram, like myelomeningocele, like syringomyelia. Okay? Spinal cord. So it's having a syrinx in the spinal cord, which is an abnormal pocket of CSF in the spinal cord. So, and we'll look at this more tomorrow, but quite often it's going to, most often happen in the cervical cord, but they can happen anywhere. But as that expands, it's going to get the corticospinal tracts. So, this gentleman he had Arnold-Chiari malformation and then fell. So he was asymptomatic, and when he fell, it just caused just enough pressure that he ended up having problems with CSF flow and had a syrinx formation. So what are we looking at here? Babinski. And what else did you see, though? Clonus. So you really don't have to test for clonus. Clonus just happens. And then here's looking at his movement. And we're not seeing involuntary movement. What do you think about his tone? I know we're not feeling it, which is the only way to know about tone, but what do you think? High or low? High. We'll go back to that picture of him in bed. Oh, I thought he transferred. I have another one of him to transfer. All right, so both of those are pyramidal lesions. The syringomyelia is in what part of the central nervous system? The myelo part, the spinal cord. And then the patient with the stroke had a cortical infarct. So both of those, cortex and spinal cord, led to those upper motor neuron signs, those pyramidal signs. For involuntary movement for our extrapyramidal system, there's several different types of involuntary movement. So athetosis we'll look at. These are writhing, rotary movements. Hemiballistic movements, these are our flailing, large amplitude, involuntary movements. And then we've got our tremors, which are small oscillating movements, and they can be intention or action tremors associated with a cerebellar lesion, or they could be resting tremors, which are typical for Parkinson's. So with our basal ganglia, lesions, we tend to have symptoms similar to Parkinson's, which is bradykinesia, which is slowness of movement, tremors at rest, rigidity, which is, what's the difference between rigidity and spasticity? Velocity dependent. What is rigidity? Yes or no? No. It doesn't matter how fast or slow you move the person, it's rigid. It doesn't move. With spasticity, if I move them, if I want to get more range of motion, should I move quickly or slowly? Slowly. Exactly. And then dystonia, which is basically variations in tone, abnormal variations of tone. And so someone who's dystonic often will kind of get themselves stuck in a posture. And then festinating gait. So here's our gentleman with Parkinson's. So this is an extrapyramidal lesion, substantia nigra. So there you see him getting up. He's bradykinesia getting up. Difficulty with initiating movement. So he's not able to start gait. Difficulty initiating. And then also difficulty, here he stopped, but then difficulty initiating also, but then those freezing episodes, does anybody remember what those are called? Freezing episodes. Where he kind of stopped. That's akinesia. But again, is he paralyzed? No. No. Okay. Hopefully these will work. Hemiballistic movements, these are associated with lesions of the subthalamic nucleus, almost exclusively. So somebody who has a stroke that involves the subthalamic nucleus has these flailing, involuntary movements on one side of the body. So he's trying to maintain himself completely still. So he has some hemiballistic movements. She has severe hemiballistic movements. And again, you can see it's on one side of the body. She's trying to provide deep pressure and approximation to slow it down. But when she doesn't do that, again, they're very severe. Again, with all of these involuntary movements, you do see changes depending on the arousal state of the individual. So that's subthalamic nucleus, hemiballistic movements. Then we've got our athetosis and our choreiform movements, which are really both writhing, rotary sorts of movements. So this woman has Huntington's chorea, which is degeneration of the caudate nucleus. So you see excessive movement of the head, involuntary movements. You see titubations or movement of the postural muscles, so she can't maintain herself still. So that's Huntington's chorea. Again, we see that involuntary movement, and these are much more rotary-like. They're not flailing like the hemiballistic movements.
How common are those?
Huntington's chorea is pretty rare. Athetosis and athetoid is not as rare. So we see in these two, we've got a basal ganglia stroke for this gentleman and athetoid CP for the little girl, which are both, but Huntington's chorea is rare. So on the left, we've got the little girl with athetoid CP, again, involvement of the basal ganglia. So you see her inability to maintain herself still. You see wide fluctuations in movement. With that woman who had the stroke who was walking, did you see her moving a lot or a little? When she was walking, did you see a lot of just movement? No, you kind of saw the same thing every time, just bringing her leg around. With athetosis, you see a lot of variety of movement. They're just not controlled. But she's unable to maintain her head in midline. She's unable to maintain her postural stability. And then this gentleman had a stroke involving the basal ganglia. And again, we see that involuntary movement, and they tend to be much more kind of rotary in nature. You tend to see people with athetosis or basal ganglia lesions stuck in this position a lot. And you've probably seen some people, even in a wheelchair or something, where they're more stuck here, as opposed to somebody who's had a pyramidal lesion and a stroke, that they tend to be up here. And then our cerebellar lesions are a whole other class. So we've got our pyramidal lesions where we have spasticity and hyperreflexia, lack of movement, and then our basal ganglia lesions where we see hemiballistic movement, we see resting tremors, we see athetoid movement, or choreiform movement. And then in our cerebellar, we've already talked about all the DISs. Dysdiadochokinesia, what's that? That's rapid alternating movement, being able to coordinate that. So you can do that with pronation, supination. You could do that with alternating toe tapping, alternating marching. We've got our intention tremors, which means the tremors during movement, not at rest. Ataxia, which is lack of coordination. Dysmetria, which is inability to grade the force or range of movement. Hypotonicity, this lack of that postural control is what really we see. So more proximal problems than distal with hypotonicity because they're not able to maintain their posture. And then dysarthria, which is the slurred speech. So this woman had a cerebellar stroke. Remember, with cerebellar strokes, our pathways are not just contralateral like we see with the other areas. So we tend to see more bilateral involvement. Maybe one side's worse than another, but it doesn't typically to present as a hemiplegia at all. So there you see her. She's doing finger to nose, so you see both the dysmetria, her ability to get to her nose, but you also see the intention tremor throughout the range.
It's not bad on that side.
And now she's going to do, oh no, she's still doing finger to nose. So there's the dysmetria and the tremor. Why can't she lift her arm up more than that? What do you think? Any ideas?
Trunk control?
Trunk control, exactly. Because remember, with a lot of times they tend to be low tone in the trunk, and so because she doesn't have that ventral medial proximal stability, she can't lift her arm any further. She can lift her arm just fine when she's in supine, but when she needs that trunk support, she doesn't. And here she is in the pool. Again, you see the tremor. And that lack of coordination, that ataxia. So again, I should be able to tell you sort of that the patient's had a cerebellar lesion, or they've had a basal ganglia lesion, or they've had a cortical lesion, and you should be able to give me a picture of what those motor deficits might look like, or what you would expect. Or I could tell you that this person has intention tremors and ataxia, and you should be able to tell me that it's more likely cerebellum than cortex or basal ganglia. Or somebody has hemiballistic movements, where would that be? Basal ganglia, which one? Subthalamic nucleus. Okay. All right, let's try this one. We've got patient's wife that says the husband had a sudden onset of slurred speech, inability to stand from a chair because he couldn't have weight on his right leg, inability to feed himself or drink with his right hand, hold the cup, he wasn't drinking through the hand. So his right hand's got some issues, his right leg's got some issues, speech has some issues, and he was drooling from the right corner of his mouth. So what are you thinking? You're thinking stroke. Why are you thinking stroke? Huh? Why would you say stroke versus, let's say, Huntington's chorea, a degenerative disease?
Because it's hemiparadic.
It's sudden, and it's paralysis or something going on one whole side of the body. Okay? So, given that it's on one side of the body, where do you think the lesion is? You think it's on the left side? Okay, where? Do we think it's the left cerebellum? No, why not? Yeah, we don't see an issue with balance. He probably does have problems with balance just because he's not bearing weight on that side, but not a balance issue. We don't hear anything about tremors, right? We don't see anything about problems with grading movement. All right, so do we think it's in the spinal cord? Why not? I mean, could be. Couldn't it? It might be.
Could be corticospinal.
Why corticobulbar?
Because of the hypoglossal.
Is it hypoglossal?
Well,
We don't know.
but it could be like it,
Facial.
yeah, any of the
Cranial nerve 7. So what do you think is spared if it is corticobulbar to cranial nerve 7? Because we said the right side is droopy and he's drooling, right? The right side is droopy and he's drooling. The eye's probably okay. Why? Bilateral innervation. Remember that the upper motor neurons for cranial nerve 7 have bilateral innervation. So with a stroke, you typically just see mouth involvement. When do you see whole side of the face involvement?
Like Bell's palsy.
Bell's palsy, which is a lesion where? Lower motor neuron to cranial nerve 7, or of cranial nerve 7, so the nerve. Why is this not Bell's palsy? It's not just the face. We've got an issue going on with the hand and with, or with the arm and with the leg. So it's not just you don't want to send this guy home with Bell's palsy. All right, so we've got right leg, we've got right arm, and we've got corticobulbar for the 7th cranial nerve, and we've got corticospinal. So left corticospinal and corticobulbar tracts, you got that above the lesion of the level of the brainstem. So the corticobulbar tract is why we get the lower face. That's also why we have the slurred speech. Okay, because he's not able to move those muscles. So that's kind of different, because when else do we have slurred speech? Cerebellar. And what's the problem there? We can move them, but we can't coordinate them. So here it's just because those muscles, if you know, you guys have all been to the dentist where you've been paralyzed in your tongue or your lips, and sometimes you talk kind of funny, right? So that's what he's doing. The right lateral corticospinal tract after the decussation is why he can't stand from the chair for the right lower extremity. And then also the right upper extremity because of the corticospinal tract as well. So, is this a pyramidal lesion or an extrapyramidal lesion? Does it involve the pyramidal tract, aka corticospinal? Yes. Okay. Where are you going? Where it's supposed to go. All right, so basically it's damage to the corticospinal tract prior to the decussation, so that's why we had the upper motor neuron signs. And here it is, just looking at it more anatomically. Again, this region in red is what's been involved. So he's had a cortical stroke that's involved the corticobulbar tracts for cranial nerve 7 and corticospinal tracts. Let's try one more and see what you guys can do. So now we're getting a CT image. We see a mass impinging the lateral region of the right lateral column of the spinal cord at L1. What would you see? So L1, right lateral spinal cord. Ipsilateral, who's saying, I hear ipsilateral a few times. Ipsilateral what, where? We're on the lateral cord. What's on the lateral? Well, we're in the actual spinal cord. Like, so not just the ventral horns, we're not in there. Corticospinal tract. I heard pain and temperature, so if we were anterolateral, yeah, because that's more anterior. So we're just having a mass, just impinging the lateral cord. So we're going to get the lateral corticospinal tract. So we're going to see signs on what side of the body? Right. Right. And where are we going to see these problems?
Below.
At, below, above, all, everywhere?
Below.
At and below. Below, below, below. So basically everything below L1, what are we going to see on the right? I heard hypo and hyper. Lateral corticospinal tracts. Are these upper motor neurons or are these lower motor neurons? Upper motor neurons. So what are we going to see? Spastic paralysis, hyperreflexia, clonus, positive Babinski. Ipsilaterally below the level of the lesion. Okay, so we're getting our lateral corticospinal tract. Depending on how big the mass is how much damage we'll have. But we're going to have upper motor neuron signs ipsilaterally. Why ipsilaterally?
Because it already crossed.
It already crossed, right? Because where did it cross?
Here.
The pyramidal decussation. So it's already crossed. So from there, it's just going to go out ipsilateral. It's going to go to the ipsilateral lower motor neurons. So all the lower extremity muscles from the hip flexors down, again, depending on how complete the lesion, they might have partial paralysis or paresis, or they might have paralysis. And so here is our lesion. Again, we've got the lateral corticospinal tracts that's not able to go to the lower motor neurons below that lesion, or below the level of the lesion, to voluntarily move or to control the reflex arcs. All right. So tomorrow we decide to start in lab, right? At 9. Sorry, I forgot about something. So 9 we'll start in lab, and then we'll spend about an hour and a half in lab, and then we'll come up and we're going to go through about 20 of these kind of things, where I'm going to either tell you the presentation or I'm going to tell you the lesion, and you guys are going to have to figure out and tell me and tell the rest of the class where it is and why it is and that sort of thing. So, and don't forget there's something outside of upper motor neuron and lower motor neuron. What else is there? Extrapyramidal, which is really what two areas?
Basal ganglia and
Basal ganglia and
cerebellum.
cerebellum. So don't forget about those when you think about your patient who has some type of motor loss. All right, you look brain dead, I know.